Welcome everyone, my name is Simba. I'm a nurse here at the Adult Secure Mental Health Rehabilitation Unit in Townsville. As most of you are aware, I've been doing my master's degree in mental health, and I'm now coming towards the end of my program. And as part of my degree, I have to do a project, and the project I've chosen to focus on and look at is going to be on electric convulsive therapy, otherwise known as ECT. I will be developing an education resource based on the clinical service guidelines for secure mental health in Townsville. So a resource for staff and a resource for patients, either in the form of leaflet or information pack. So I'm going to show a series of slides and some videos as well that will help depict ECT in a way that you will all understand. So sit back, enjoy, relax this presentation. My rationale for this presentation is that staff within the Secure Mental Health Rehabilitation Unit have equally varied experience in the implementation of ECT as a treatment option. Nurses have expressed relative knowledge about ECT. Others refer appropriately to clinical practice guidelines, however express a lack of confidence in one, explaining ECT fully, and secondly, educating their peers and clients about ECT. Some nurses have never been to an ECT suite. I myself have been a nurse for 13 years plus, and my first encounter of seeing ECT being done in the ECT suite was actually this year when I escorted a patient across. For reasons being, ECT is not actually performed in this unit of secure mental health. It's actually performed across the road at a separate unit, adult inpatient acute mental health unit. And again, being that most of the time I'm in charge of the shift, it makes it very difficult for me to leave my post. So as a result, I have to delegate various staff members to take the patient across. And this then limited my knowledge and understanding of ECT and limited my ability in explaining fully the process of ECT to patients who are going through or being prescribed as a treatment option. The outcome of this project is to develop an education resource based on current clinical practice guidelines for ECT. The resource will assist nursing staff to have a better insight and confidence in teaching and educating clients and fellow peers regarding ECT treatment. What is ECT? Electroconvulsive therapy is a procedure which electric current is passed through the brain, triggering a brief seizure. This seems to cause changes in the brain chemistry that may alleviate symptoms of certain mental illnesses. I'm going to go and show a video on the history of ECT, and I hope that you will enjoy it. It's very detailed, but it's a short clip, and I couldn't have put it more there than this video.
As early as the 16th century, agents to induce seizures were used to treat psychiatric conditions. In fact, Benjamin Franklin wrote that an electrostatic machine cured a woman's electrical fits. Convulsive therapy was introduced in 1934 by a Hungarian neuropsychiatrist called Ladislas Meduna, who, believing mistakenly that schizophrenia and epilepsy were antagonistic disorders, induced a seizure first with camphor and then with metrosol. Italian professor of neuropsychiatry Ugo Cerletti had been using electric shocks to produce seizures in animals, and with his colleague Lucio Bini developed the idea of using electricity as a substitute for metrosol in convulsive therapy. 1938, they experimented for the first time on a person. Gerletti had noted that a shock to the head produced convulsions in dogs. Once they started trials on patients, they found that after 10 to 20 treatments, the results were significant. Patients had much improved. ECT soon replaced metronidazole therapy all over the world because it was cheaper, less frightening, and more convenient. Gerletti and Beatty were nominated for a Nobel Prize, but didn't receive it. Throughout the 1940s and 1950s, the use of ECT was widespread. In the early 1940s, in an attempt to reduce the memory disturbance and confusion associated with the treatment, two modifications were introduced. First, the use of unilateral electrode placement and the replacement of sinusoidal current with a brief pulse. In the 1940s and early 1950s, ECT was given without muscle relaxants, and the seizure resulted in a full-scale convulsion. A rare but serious complication was fracture or dislocation of the long bones. The introduction of succinylcholine in 1951 led to a more widespread use of what was called modified ECT, with a short-acting anesthetic usually given in addition to the muscle relaxant. The steady growth of antidepressant use, along with negative depictions of ECT in the mass media, led to a marked decline in the use of ECT during the 1950s and 1970s. In 1976, Dr. Blatchley demonstrated the effectiveness of his constant current brief pulse device. This device eventually largely replaced earlier devices because of the reduction in cognitive side effects. The use of ECT declined until the 1980s, when use began to increase amid growing awareness of its benefits and cost-effectiveness for treating severe depression. Because of the backlash noted previously, national institutions reviewed past practices and set new standards. In 1976, the American Psychiatric Association released its first task force report in which new standards for consent were introduced and the use of unilateral electrode placement was recommended. This was a brief summary of the history of ECT from the Center for Education.
As we can see, ECT has improved immensely over the years. Modern ECT is considered to be much safer now, with patients receiving anesthesia and sedative medication, which reduce the risk of severe injuries as demonstrated in the ECT and in the video. ECT is now being commonly used around the world because of its safe nature, and Queensland Health supports the use of ECT both in metropolitan and regional areas such as us here in Townsville. There are several myths about ECT, and I'll read out quite a few of them and try to give facts about ECT. ECT makes people forget everything. The fact is that short-term forgetfulness can be a side effect, which is usually mild and reversible. This is limited to recent events. The ability to remember will return after ECT course is completed. The second myth is, if a person gets admitted to a psychiatric hospital, she would be given ECT without her permission. The fact is that before someone can be given ECT, they have to consent to the treatment, or a decision can be made by the Mental Health Review Tribunal in support with guardianship and attorneys if the person lacks capacity to give consent. Another myth is that ECT experience is painful and horrifying, especially with movies such as One Flew Over the Cuckoo's Nest, or even the history of ECT, where the methods were barbaric in those days. So the fact is that patients given ECT under anesthesia will not feel pain or the electric shock. Another myth is that ECT causes brain damage and may reduce intelligence or personality. The fact is that ECT does not cause brain damage. It may cause temporary memory lapses of events around course of ECT. ECT does not affect personality or overall intelligence. Another myth is that ECT is given as a punishment. ECT is not a punishment. It is administered to treat a person's psychiatric conditions. Moreover, it is not a painful procedure. Another myth is that ECT has been suggested by the doctor. It means that other treatments are not working and the condition is hopeless. The fact is that ECT is generally suggested by the doctor as among the available options. It is best for the patient, and if it is best for the patient at that moment. If one does not wish to receive ECT, the doctor would suggest alternative options. Why is ECT important? In many researches I've read, the procedure has shown to help approximately up to 78% of people with clinical depression, certain mental illnesses, and to those with these illnesses that don't respond to medication or talking therapy. The reason ECT is so effective remains unclear. Some researchers believe it helps to correct imbalance in the brain's chemical messenger system. Other theories is that the seizure somehow reset the brain. Indications of ECT. Consumers must have the diagnosis of the following. Indicate a preference for ECT for a person and their family or carers. We live in patient-centered care, so if a patient feels that ECT is probably best works for them and they're not receiving any outcomes from the treatment they're receiving, they can suggest to have ECT done. A past history of illness and treatment responses as well is considered. A certain degree of suffering of the person. The relative need for rapid response to treatment, e.g. in the case where someone is feeling highly suicidal because of their depression. The risks and benefits of ECT identified in comparison to other appropriate treatments. Indications of ECT. ECT is highly effective treatment with a strong evidence base, particularly for the treatment of severe depression disorders, especially when one or more of the following features are present: catatonia or psychotic features, suicide risk, failure to eat and drink adequately, inadequate response to antidepressant medication, or prior response to ECT. Major severe depressive disorders, non-responsive catatonia and schizophrenia, uncontrolled and prolonged mania in bipolar disorders, non-responsive postnatal psychosis and postnatal depression. And it's also indicated when drug therapy is contraindicated or where there is a risk of neuromalignant syndrome. How frequent is ECT used? ECT is generally used typically 2 to 3 times per week, with the course varying from 6 to 12 treatments. Some patients start seeing evidence of results after 3 to 4 treatments. If needed, maintenance ECT can be provided on an outpatient basis if there is a clinical indication for it. Maintenance ECT is done on a weekly or monthly basis. The side effects. What are the side effects of ECT? ECT can have some side effects ranging from serious side effects that can be caused by post-anesthesia. Some of these may include headaches, nausea, muscle pain, amnesia, drowsiness. Contraindications for ECT, which means ECT should not be given if a patient has a raised intracranial pressure, history of cerebral bleed or aneurysms, recent myocardial infarcts, IM, recent strokes, arrhythmias, or anesthetic risks. What are some of the ethical problems and considerations with ECT? The idea that ECT can have a negative impact on someone can result in extreme anxiety. It is unethical to withhold ECT treatment for someone if it could save their lives. While some consider ECT to be beneficial, others report feeling shame, terror, distress, and an invasion of personal autonomy, especially when ECT is administered with the approval of mental health review tribunal, simply because the person has not consented but the team feels that this is the best course of action. Care must be taken to impart information regarding the potential of cognitive impairment following ECT. The nature of cognitive impairment experienced by individual is variable to a degree that it may overweigh the individual perception of any benefits of treatment. Now we're going to focus on consent process for consumers prescribed ECT as per Queensland Health Clinical Practice Guidelines of 2016. The consumer must be given information in a format that they can understand, both verbally and written, and if necessary, an interpreter to be required. Information must be evidence-based, and the information of the potential adverse effects must be given. Information must be discussed with the consumer, their next of kin, and other family members, according to the will of the person. Doctor may perform ECT only in an authorized mental health service. The patient must give informed consent for the treatment. If the patient is an adult who is unable to give consent, informed consent, the Mental Health Review Tribunal has to approve the treatment. Before a person is given informed consent, the doctor proposes to provide the treatment must give the consumer a full explanation in a form and language able to be understood by the person. The purpose, method, likely duration, and expected benefits of treatment, and possible pain, discomfort, and risk and side effects associated with the treatment, and alternative method of treatment available to the person. The consequences of receiving treatment must be clearly outlined, of not receiving treatment must be clearly outlined to the consumer. In some cases, emergency ECT may be necessary to save the person's life or to prevent the person from suffering irreparable harm. In the circumstances, the Act allows the doctor to administer ECT in an authorized mental health service for an involuntary patient subject to treatment authority, forensic order, or treatment support. A person absent without permission from another state who is detained in an authorized mental health setting and has deteriorated and in need of ECT can be provided ECT in this instance as well. A psychiatrist may apply to the tribunal to perform ECT in the approved form. The psychiatrist must be satisfied that ECT is the most clinically appropriate treatment option for the person, having regards to the person's clinical condition and treatment history. It is recommended that a second opinion from another consultant psychiatry accompany the application for MHRT. A detailed history of prior treatment course of ECT should be included with the application submitted for MHRT. A person who is subject to an MHRT hearing is entitled to free legal representation. In deciding whether to approve treatment, the tribunal must consider any views, wishes, and preferences an adult has expressed about their treatment in an advanced health directive. If the application relates to a minor, the tribunal must consider the views of the minor's parents and the views and wishes preference of the minor himself. The tribunal must give the approval only if satisfied that the preference of treatment Evidence supports that the effectiveness of this therapy for the person is their particular mental illness. If the therapy have previously been performed on the person, the effectiveness of the therapy for that person. If the tribunal gives the approval must state the number of treatments that may be performed in the stated period under the approval and may be made subject to conditions the tribunal considers appropriate. A consumer can apply to the mental health court within 60 days for appeal should they disagree with the MHRT decision. In the situation, in emergency situation, ECT may be performed without the person's consent if the doctor or senior medical administrator of a service certify in writing that performing ECT to the patient is necessary to save the relevant patient's life or prevent a relevant patient from suffering irreparable harm. An application has to be made to the tribunal to perform ECT for the patient. Review within 5 days of a tribunal must be done. A patient can be present by can be represented by self, allied person, or attorney. Preparations for ECT. Pre-treatment assessments and physical examinations have to take place. ECGs, consent forms have to be in place and signed. Benzodiazepines have to be seized 12 hours prior to ECT being done because they raise the threshold for ECT, and so as sodium valproate as well. An anesthetist assessment has to be made available or has to have been carried out. Preparation for patients. Psychoeducation must include video or text. ECT orientation. The patient must be taken through the ECT suite and explanation of the whole process and procedure be shown prior to ECT being done. The use of a memory diary should be encouraged due to some of the memory lapses that do take place after ECT. Physical fasting should be done 8 to 6 hours before ECT. Medication that can be given is only cardiac and antihypertensive drug, reflux bronchodilators, and are the only drugs that can be given before a person has ECTs, or should be given if a person has these conditions. The role of a nurse in ECT is to ensure that satisfactory requirements are met, meet the person's psychological needs, monitor the person's physical well-being, assist and support medical staff in the use of equipment, support and educate consumers and their families, carers and significant others, support, guide and educate all nursing staff to ensure the facilitate best practice. Pre-ECT nurses' responsibilities. Before ECT, you have to make sure that the person has been fasting for at least 8 hours, the minimum of 6 hours. Take the patient to the toilet so that they can urinate before the procedure. Remove any hairpins and dentures or any chains. Take and record physical observations. Help reduce the person's anxiety. Post-ECT nurses' responsibility. When the anesthetist gives 100% oxygen until breathing is unassisted, the RN then monitors the for any respiratory problems. Reorientation of the person, time and place is done. That's the recovery room. Continued observations until person is oriented and steady and memory loss has disappeared. Record all aspects of treatment of the recovery. Next, I'm going to play a video that just depicts what happens inside an ECT suite, and I hope you find this beneficial.
They would need to see our general practitioner first and just have some routine blood tests taken and a ECG reading of the heart just to make sure that that's okay. And then the treating psychiatrist would obviously sit down with the patient and discuss ECT and what it's involved and how it works and get the consent of the patient.
ECT, you'd be woken up quite early, say about 6:30. You would be fasting from 9 to 4. Staff would bring you to a small waiting room where you wait until the next turn. That waiting room usually goes straight to the ECT suite. So when it's your turn, we would come and call you. You walk in, we would ask you to lie in bed. Two things happen while you're lying in bed. One is that the anaesthetist puts in a small needle in your vein, and that's to give you the anesthetic to put you to sleep. At the same time, the psychiatrist sticks, just quite small little spongy pads on your forehead, behind your ears and one of your chest. What they do is they pick up tiny electrical currents and they monitor your brain waves during the ECT. Technically, it's called an EEG, and you might have had a version of this in the neurology clinic, for example, where they're just measuring your brain waves to see what your brain wave pattern is like. This is one of the ways we monitor ECT. We might put a little blood pressure cuff around your ankle, and again, it just helps us to monitor the treatment. When everything is ready, then the anaesthetist would give you a bit of anesthetic into the vein. The anesthetic nurse would hold just a mask for you to breathe oxygen as you're going off to sleep, and you fall asleep very quickly. So typically within a few seconds of the anesthetic being injected, you will fall asleep. While you're asleep, then the anaesthetist makes sure that there's plenty of oxygen in your body, and the psychiatrist that administers that very brief current for a few seconds across the brain. You would then have, say, about a 30-second seizure, and there's very little seizure activity to see because of the anesthetic agents. The seizure naturally comes to an end, and then you would gradually wake up, usually a few seconds after that. We make sure that you're fine, we turn you on your side so that, just in case some saliva comes out, doesn't go down the wrong way. Then we really go up to the recovery room. You would wake up there, there'd be a nurse looking after you. Typically you'd spend, say, about 10 minutes there, and you're gradually becoming more and more awake. They're measuring your blood pressure and your heart rate, and then they would get you up when you're ready, and then you would go back to the ward.
I hope you've all enjoyed this presentation. Now I'll leave it to the question and answers. And if there's anyone who's got questions and answers, you may go ahead. So thank you everyone for listening to my presentation. Now we're coming to that section for questions and answers. So I don't know if anyone has any further questions about what we discussed.
I've got a question, please, Simba. I just want to know, in Queensland, can children be administered ECT?
In Queensland, under the clinical service guidelines, children can receive ECT. However, it is deemed the last resort, and evidence has suggested, even here in Townsville when I was doing my research, that maybe they would have had 1 or 2 children over the last few number of years. So it's not a treatment option that they generally tend to want to administer to children. However, if the need is paramount that this child has to have ECT, then obviously being a minor, they can't give informed consent. They have to get informed consent from the parents, and a solicitor has to be provided as well. And then it goes to the mental health review tribunal, who actually at the end of the day makes the ultimate decision, but also taking into consideration the views of the parents and the views of the child as well will be taken in place. So yes, it does get given, but as a last resort, they generally tend not to, but in the provision of the Mental Health Act and the clinical service guidelines, ECT can be provided to kids.
Thank you.
Okay.
I've got a question. Can anyone refuse to have ECT against their doctor's orders?
Now, in the situation where we are right now, where a lot of our patients in a secure unit are under the forensic order or treatment authority, if the doctors deem that treatment is necessary for this patient, the patient has the right to refuse. But if the doctor, because they're under the Act, and the doctor feels that ECT is the way to go, then they have to then get a second opinion. It's patient's right to get a second opinion doctor. If they collaborate that with the doctor that this is the treatment that is necessary, then an application is made to the Mental Health Review Tribunal, and they're the ones who make the ultimate decision whether or not ECT is to be granted. But the patient still has rights to appeal against the decision for the Mental Health Review Tribunal, and they have up to, and this might take up to 60 days, and the appeal process is done through the Mental Health Court, not the Mental Health Review Tribunal. So it's done through the Mental Health Court, and they're the ones who then make the decision whether or not it should be stopped. But once it's approved by the Mental Health Tribunal, generally it tends to go on until a court date is placed. But legal advice would be provided. The patient has to have legal advice and all the necessary steps taken.
Okay, thank you.
My question is, do you got good resources about this topic that you could provide for our colleagues and for clients as well?
Yes, so that's part of my project for this. That's why I'm taking this project to actually develop an education resource, a resource that is tailored for our unit specifically, because ECT gets done on the other side. So I will be looking at doing some slides. I will be looking at doing some information packs. As for the patient, I'll do patient leaflets that are going to be easier to understand, that we can refer to and potentially give as much information. But your contributions as well and your support in developing that will be very much welcome.
Thank you.
Alright, thank you very much. I hope you've enjoyed this presentation. I'll give you a list of references that I've used, and I also have this presentation available on the computer that you can access as a quick reference guide until I then develop the final product. I'd like to thank each and every one of you again for coming out and spending time listening to my presentation, and I hope that you found it extremely beneficial. Thank you.
Thank you.
So attached are my reference lists. I've got about 4 pages of references from the various articles I've read in the various books that I've read, which have assisted me in getting much more clear understanding of what ECT is about. I will provide this at the end of the project, and feel free to approach me and ask me questions anytime. Thank you.